So welcome back. Hope you all had a good lunch. So the next speaker you've heard from already, Antonio Presenti, and his next talk is going to have ask the interesting question: does NAVA have a role in ARDS? It's an interesting question. Well, hopefully we'll get an answer. So Antonio, are we going to get an answer? Maybe. It's going to be a definite maybe. Did you turn on your mic?
Yes.
Okay.
Now that I have my mic on, I can talk.
Oh, you're right.
So, does NAVA have a role in ARDS? Perhaps. Now, as usual, I did a Medline search. NAVA and the ARDS, 7 papers. And most of them, 3 of them I could not read because I don't know the language. But there is not much in literature about the ARDS and NAVA yet. So first of all, the first question is, do we need spontaneous breathing in ARDS? Because most people think or use controlled mechanical ventilation in ARDS for most of the time. Now we know that controlled mechanical ventilation has indeed some advantages, but there's a lot of disadvantages too, like water and salt retention. You all know that patients mechanically ventilated usually get bigger and bigger and bigger and bigger, particularly if we want to maintain their cardiac output and hemodynamics in basal condition. Most of them require some heavy sedation. And we know that controlled mechanical ventilation leads to respiratory muscle atrophy. We have heard about it this morning too. I'll be very quick. We have many proofs that mechanical ventilation, controlled mechanical ventilation, very quickly, in a matter of days, if not hours, leads to diaphragm atrophy and respiratory muscles atrophy, which becomes a major problem particularly for weaning. So spontaneous breathing, preserving spontaneous breathing, does it have any advantage? Well, first of all, the main advantage in my mind is decreased intrathoracic pressure. I'm sorry to go back to this extremely basic physiology, but it's very important. During controlled mechanical ventilation, intrathoracic pressure is positive and increased. Hemodynamics are impaired, while during spontaneous breathing, the intrathoracic pressure is negative and hemodynamics are favored. So spontaneous breathing means better hemodynamics and lower central venous pressure, that is, lower peripheral edema. You know that a few years ago we all around the world we used very liberal fluid replacement politics, particularly in postoperative patients. And I remember a paper from Australia in which in 2 days the patient gained an average of 18 kilos during controlled mechanical ventilation. Then there are advantages on tidal volume distribution because during controlled mechanical ventilation, most of the tidal volume is distributed in the upper regions of the lung rather than in the posterior regions like during spontaneous breathing. But I don't want to give you a lecture on how good is spontaneous breathing. I'm not saying that there is no role for controlled mechanical ventilation in ARDS. We know that, particularly during the initial stage of ARDS, a period of controlled mechanical ventilation and perhaps paralysis is favorable in terms of outcome, and this has been shown. We have seen the paper of Papazian this morning, so I will not go through it. But point is that as soon as possible, we should try to go back to spontaneous breathing. And over the years, I'm talking about the last 20 years, we've been favoring pressure support ventilation in ARDS. And 10 years ago, we published a paper on the early application of pressure support ventilation in ARDS patients. Those were quite severe ARDS patients. The average PEEP was 15 centimeters of water, PO2 was 80. And in a good proportion of those patients, in spite of the early application, we had successful application of pressure support. But in 10 of those, we had failures. That is, we had to go back to control mechanical ventilation. And now, if I went back to look at this older paper of ours, and what is the difference between patients that could stand pressure support and patients who could not stand pressure support? Well, PCO2 was slightly higher during controlled mechanical ventilation. Minute ventilation was slightly higher. Respiratory rate was slightly higher. But most of everything, respiratory compliance was lower. Here, this line, total static lung compliance. Success patient, at the time they were put on controlled mechanical ventilation, had the compliance of almost 42 milliliter per centimeter of water, while failing patients, those that could not stand spontaneous breathing, had a compliance of 30 milliliters per centimeter of water. The lung were, as we used to say those times, stiffer. We would say their lung were smaller, according to the concept of the baby lung in ARDS. So we reasoned actually that NAVA could be an advantage in those patients with a lower compliance. Why? Well, this is what my friend Paolo would call a representative patient. Mm-hmm. And you see, this is a patient that has a so-called double triggering. You see, this is the EDI, and yes, the pressure support makes 2 breaths, while the brain wants to make a single breath. This is particularly occurring in patients with very low compliance. The compliance of this patient was 10 milliliters per centimeter of water, very stiff chest. This is obviously, we could qualify it as an asynchrony. I will not spend time on this paper. We have heard a lot about this morning. So we know that synchrony is very important. So let's go to this one again. This is a patient with even a lower compliance, 7 milliliters per centimeter of water. This is wrong. It's 7 milliliters per centimeter of water. Impossible to ventilate. Very high pressure. The patient was on ECMO. I'm mixing up a bit my two speeches, but ARDS, patients on ECMO usually have ARDS, so it's approximately the same thing. And you see here a double triggering with pressure support, while NAVA, as a matter of fact, allows a total synchrony between what the patients want to do and what the machine does. So once again, in this particular category of patients with very low compliance, like the very severe ARDS patients are, NAVA would allow an earlier application of spontaneous breathing when compared to pressure support. What else do we expect from mechanical ventilation, mechanical support during ARDS? First of all, protective ventilation. We have heard about ventilator-induced lung injury this morning, and we know that for time being, evidence-based wisdom tells us that ventilator-induced lung injury is prevented by tidal volumes equal or lower than 6 milliliters per kilo. And this is a study recently published in intensive care that shows that going from pressure support to NAVA, when we increase pressure support, PO2 stays the same approximately, tidal volume increases from 6 milliliters per kilo to 9, while it changes very little when we increase NAVA. And this is a paper by the group of Paolo Navalesi. So, even in ARDS patients, tidal volume is maintained and PO2 is maintained. This is a paper by our group comparing in a population done in which all patients except one have ARDS. When we compared NAVA with pressure support, we had 5 NAVA levels from 0.5 to 4, and 4 levels of pressure support from 4 centimeters of water support to 16. And once again, you see that tidal volume is almost perfectly constant around or below 6 milliliters per kilo during NAVA, while if we increase pressure support in these patients, tidal volume jumps up from 5 to almost 9, 10 milliliters per kilo. So once again, in this group of patients, we could say that NAVA gives us a better compliance with a lung protective strategy because the tidal volume stays more constant. Moreover, during NAVA ventilation, even if we increase it, the variation of tidal volume is maintained closer to normal variability. You know that a major drawbacks of controlled mechanical ventilation is the monotony of tidal volume. A very constant tidal volume, particularly a low constant tidal volume, causes atelectasis. So what we normally do, what I normally do, what you normally do, what Artur Slasky normally does, is to make a sigh every so often and to change the size of tidal volume from one breath to the other. So the variability of tidal volume is maintained during NAVA. That is associated to the changes in EDI, because this variability comes from the brain, and the machine follows it, while in pressure support, the variability is much smaller and decreases with increasing support. Obviously, not everything is good with NAVA also. There are patients that when we over-assist them, when we increase the NAVA level, escape from the rules of constant tidal volume. This is a plot of the response of individual patients at increasing NAVA levels. This is the frequency of tidal volumes over 8 milliliters per kilogram. And you see that in these patients, no respiratory breath goes over 8, sorry. But in this particular patient, when we go over 2 of NAVA assistance, then quite a few breaths escape the rule of staying lower than 8 milliliters per kilo. So, I would conclude here that most patients cannot be over-assisted by NAVA, but the occasional patient can be over-assisted, and we can see it by the fact that tidal volume escaped the rule of staying constant. However, this variability of tidal volume is very good because it maintains gas exchange and lung volume. During pressure support, we have to use PSYCH to maintain oxygenation and to maintain the lung volume, while with NAVA, we don't have to do that because the brain itself does it. This is pressure support, and you see here the variability of EDI, which is not followed by a variability of tidal volume. While during NAVA, the variability of EDI, first of all, is bigger. We have a bigger variability of EDI, and we have also a much bigger variation in tidal volume. I would dare to say that during NAVA, the patient might be allowed to perform a physiological PSYCH when he wants to. So in conclusion, spontaneous breathing does have a role in ARDS, first of all. Pressure support has limitations. NAVA improves synchrony, maintains oxygenation, and in most of the patients, the protective ventilation is automatically applied by preserving the ability of performing PSYCHs at physiological frequencies. Well, my talk is finished, but I wanted to show you this slide that shows you, it goes back to the discussion of this morning. It shows you EDI in patients plotted against the pressure developed by muscles. And you see that the higher the EDI, the higher the pressure developed in the single patient. But the slope might be different. Most of the patients, this is a very small number of patients, but most patients are lumped here at the center, but some are either have a very small slope or a very high slope. This is a bit too physiological, but it means that in the individual patient, we can predict the patient's work from the EDI level. This is variable between patients in our experience. But once we have got a few points, we can predict and we can work knowing exactly how much work the patient is doing compared to the work the ventilator is doing, which might be very helpful in difficult weaning situations. Thank you very much.
Don't leave so fast. Hey, questions from the audience? I had one question, Antonio. The hypothesis you had about the one patient that was pretty dramatic who had a greater than 80% of the breaths were bigger than 8 ml per kilo. So the question has to do with, could that have been a good thing in a way? In other words, 6 is an arbitrary number. Clearly, it might depend on a number of factors, and maybe in that particular patient might have even been still protective. Did you plot, because we looked at data like this, did you look at, and I don't remember this in this paper, did you look at the size of the tidal volume versus their compliance, for example, to see whether that...
Not in this group of patients. Yeah. I have another slide on the next speech about ECMO with compliance, but in this group of patients, what I can tell you is that the higher the baseline EDI, the higher the change in response, increasing the NAVA level.
Well, what I'm getting at is you have a patient who has relatively low compliance. My guess is with NAVA, when you use NAVA, whatever level, the tidal volume would be relatively small. Higher compliance, higher tidal volume.
Oh, I have to think about that. But what I can tell you is that the patient with the lower compliance will most probably have the highest EDI. And so he will have a high, if he is in good shape, he will have a high muscle pressure, and obviously, well, obviously it's not obvious. I don't have the answer. Please.
Titrations in they weren't all ARDS patients, but we plotted lung compliance versus tidal volume and found those who had stiffer lungs had lower tidal volumes. Yeah.
There's another question.
That is, stiffer lungs had lower tidal volumes.
No, the patients with the stiffer lungs spontaneously chose lower tidal volumes than those with healthier lungs.
So it's kind of a repeat question I had before, but so when you have these kind of data, then how do you choose what data to listen to on a patient and what not to? So Dr. Slutz's point about the 8 per kilo may be fine for that particular patient. The PIP of 40 may be fine for that particular patient in that particular situation. So what are you looking at on NAVA to determine when you're okay with high tidal volumes, when you're okay with high PEEPs, and when you're not?
At this time, I cannot give you suggestion about the selection of PEEP in ARDS patients and NAVA. As a matter of fact, what we do is that we keep the same PEEP we had in pressure support, which is not a great help in answering to your question. As a rule, we try to maintain tidal volume lower or around 6 milliliters per kilo, average. That is, we try to maintain, since increasing the level of support increases also the variability. We select the amount of support in NAVA to maintain enough variability, but around 6 milliliters per kilo. I know it's common wisdom, nothing.
Your question's a very good one. I would say there's no answer to the question yet. We don't know yet what. I mean, not my hypothesis. The hypothesis you might generate is suggest as well with NAVA, the patient's telling you, and unless they have something in the central nervous system that's going to really alter things, that if they picked an 8 ml per kilo, that may be fine for them.
My idea is that something gets cheated in the brain of the patient, and he escapes from the normal control because he gets too much tidal volume compared to what he wants. And you see, when he goes to 10, 12 milliliters per kilo, I think that is 80% of the breaths. I think that is outside what we expected, what we want NAVA to do. So either something is wrong with the algorithm or something is wrong in the control of the patient.
Yeah, it's hard to tell from this graph though, because let's say that's a percentage of tidal volumes greater than 8. If that patient at baseline is 7.99, slight increase, right? So just the graph alone doesn't tell it all. Paolo, you had a comment. Could you pass the microphone forward?
Yeah, the point is about the issue of the ML. What are the mechanisms that determining the control of the system? So if we assume that our chemo and mechanoreceptor, and we say that sedation also influences, it's pretty difficult to arrive to a synthesis and to end up in one answer that solve all the problems. It's probably the interaction of different factors, as you, I guess,
Well, it's not
suggested.
just that. When we're thinking about ventilator-induced lung injury, what's the mechanism that cause a ventilator-induced lung injury?
Yeah, but it is the same.
Well, is it? That's the question.
Look, I don't want though that to give you or you to go home, not you personally.
He's going home. He's leaving.
Not you to go home
I'm
with
leaving.
the wrong message. Because we are focusing our attention to one patient that escaped from the control. But most of the patients, I mean, the rule is that patients in NAVA stay on a lung protective tailored tidal volume.
But for the same reason, I think mechanoreceptor are the major determinant of this effect. In my, as we discussed today, in my little experience in ARDS patients, those with a behavior, the more pressure, the more NAVA level you give to the patient, the higher the volume, and I arrived to see 20 ml per kilo increase in the NAVA level, are those with interstitial disease. Don't ask me why, but I have at least 3 or 4. I mean, interstitial pneumonias are those who are not working with a plateau effect.
You mean something like viral pneumonia or chronic?
Viral pneumonia,
Oh.
for example.
Yeah, it might be. But
So, Chris, just keep it short because there's a question in the audience.
I think we spent in our lab about the last 4 or 5 years to try to sort out step by step what's the thing that makes tidal volumes go up when we don't want them to go up. And it's clear that the lung receptors are protecting. And we've shown this in CT scans, we've showed it in healthy subjects, we've showed it in humans, we've showed it everywhere. So the lung receptors are protecting the lungs. But there's a compromise going on all the time. So when the guys who are in the lung calls the brain and the brain says the CO2 is way too high, the pH is going haywire, they're going to get the order from the top level, say that, you know, whatever you say, I'm going to increase the volume anyway because we have to get the CO2 out. If you can't do it by increasing just respiratory rate, and there is no program for just increasing just respiratory rate, so you would increase both respiratory rate and tidal volume. So these guys are slowly drifting up. As the baby lung becomes smaller, the dead space is still the same or increased. And there has to be increase. So I could tell you just one thing. If you have 2 lungs and you breathe with a severe lung injury, and I give you the highest NAVA level you can get, you would never get more than 4 ml per kilo. Then you have 1 lung, same injury, and I give you, you would not get more than 5 ml per kilo. That sounds good, doesn't it? But remember now, 2 lungs, that means 4 ml divided by 2. That's 2 ml per lung. Whereas the other one has 5 per 1. That's 10 ml per lung if you have 2. That's how it works. Like CO2 is something that has to leave the body. If you can't do it through ECMO, you have to do it through the airways. That's the way it works.
Last question at the back. Do you have the microphone? Okay.
Caught me by surprise.
Hi, I'm Ernie. I'm one of the clinical application specialists. My question is, as far as tidal volume goes, what about focusing then on total minute ventilation, minute volume, things of that nature?
I would like very much to focus on minute ventilation. And I can tell you that minute ventilation does not increase while increasing NAVA levels. However, most clinical scientists pay very little attention to minute ventilation as far as ventilator-induced lung injury is concerned. You know that ARDS is a disease that requires very high minute ventilation, 15 liters per minute, 16 liters per minute. And even when we use protective ventilation, we still use very high minute ventilation.
So I think that it depends what your question is in terms of use of minute ventilation. For looking at severity of ARDS, I think it makes sense. In fact, there's a new definition going to be coming out about ARDS, the Berlin definition, that for the very severe group is going to include probably a minute ventilation has to be greater than something to be in that group.
Correct.
So that's one thing. Corrected for PCO2 and all that. But the issue is for you can think about ventilator-induced lung injury. What are the mechanisms? Well, if you had, let's say, just a minute ventilation of 5 liters a minute, but only one breath, your minute ventilation is 5, but your tidal volume is 5, you're going to cause ventilator-induced lung injury. So I think their lung stretch is more important than minute ventilation. I think the breath by breath variation. So anyway, time to move on.